Is this better? Okay, thank you so much and welcome to our virtual plenary. We're very pleased to welcome you to this session, and I'd like to introduce our friend of the festival, Dr. Cherian Vargasi, who's the regional advisor for non-communicable diseases at Premature. Cherian, can you hear us?
Yes, Arpana. Good morning, good afternoon. How are you? I can hear you well. Hope you can hear me.
Thank you so much.
You can hear me. Can I proceed?
Yes, please, Cherian, over to you.
Okay, thank you. Good morning and good afternoon, ladies and gentlemen. It's a pleasure always to be part of the Manchester Public Health Festival. I have been a regular for the last 3 or 4 rounds, and it's always, it makes me learn a lot of things, as well as it brings a wide variety of topics, which is so critical for advancing global public health in the post-pandemic period. So for this session, I will take you through briefly the need for accelerating non-communicable disease response at the national level. As you know, we have a sustainable development goal target of reducing premature mortality, that is the mortality from non-communicable diseases, by 1/3 by 2030. That is only 8 years from now. And the world is certainly not on course. This is a very interesting global mortality graph, which the waveform helps you to understand the epidemiological transition, the classical epidemiological transition. This is the world as a whole, but if you look at Africa, Asia, and Europe, the green bars are the communicable disease and the light blue is the non-communicable disease. You can see the wave pattern really sort of going down, and by the time you reach Europe in 2019, it's almost light blue. It also shows that the world is, Asia is about 20 years behind Europe and Africa is behind 20 years behind Asia. So, but at the same time, we have to have titrated appropriate responses to make sure that non-communicable diseases, which as you can see, are difficult to contain like what we have contained communicable diseases. So the traditional approaches to public health are not going to work entirely in non-communicable diseases. So this is the global trend in premature mortality from 2000. If you see, the blue line is if the current trends continue, the trends are in the right direction, but to reach the 2030 target, it has to go much steeper. So as you can see, people are struggling and they are in the right direction, but I think they need to bend a bit more to reach where they should be. On top of it, COVID has hit us badly. And if you look across the world, people suffering from non-communicable diseases were the ones who hit most, either in terms of severe disease or death. More than that, when service disruptions were looked into, whether it is hypertension, palliative care, dental care, or cardiovascular emergencies or rehabilitation, 50 to 60% of countries across the world in the WHO survey reported that services were disrupted, and some of them were completely disrupted. So the big ones affected were cancer screening services, early detection programs, compliance support for people on long-term medication. So this might even affect some of the gains that we have reached in the last 20 years. But if you look at the overall policy implementation for non-communicable diseases, I will see the glass as half full, because these are new territories, whether it is smoke-free policies or fat policies or alcohol advertising bans. These were not in the lingua franca of the public health people for many years. These are relatively new, but even then, I think the public health community has really helped member states to advance some of these. Tobacco policies have really gone forward, but others, we need more work to make them happen. When it comes to public health systems, as I always say, the current disease burden itself is too heavy, and we are we cannot just keep on beating this horse, which cannot even lift the current public health and other health burden. So if you want to really be agile and fast, what is needed? So you have to have a small number of prioritized interventions. So at globally, as you know, the World Health Assembly has just approved in May a roadmap which we prepared based on this, because the basis is health in all policies, primary healthcare, universal health coverage, and health security. Then there are a lot of gains like in tobacco control that we have achieved, which should not slide back, so we have to sustain them. But the most important is to prioritize, accelerate, and innovate. And innovation, especially with the COVID era, has really shown us that a lot of innovation which were lying low were taken forward and made public very fast. And then, of course, we have to have more accountability, not just in health sector, but sectors in other than health to ensure that things happen. So one of the obvious ones to accelerate is the prevention of childhood obesity. Childhood obesity is a time bomb, which is really worrying. A lot of efforts are needed at the individual level, but more than that, the food industry has to play a significant role in reducing fat, sugar, and salt content of processed foods, in reducing or controlling marketing to children, which is a major challenge. And often, as we find these days, it is digital marketing. So the conventional restrictions to marketing also may not to apply in this digital world. So I think more intuitive and innovative approaches are needed by the public health community to look at how do we control the emerging issues like digital marketing. We have to use the global mortality database in a much better fashion. And this is one example from the Lancet paper on pathways for achieving the SDG target. It actually looked at the different NCDs, whether it is ischemic heart disease, lung cancer, or stomach cancer, and looked at the yearly percentage change in cause-specific probability of dying. So the ones in red, which are mostly cancers, are the ones the yearly percentage change is more than 1%. But cardiovascular disease, which is in blue, and respiratory disease is actually going down in the sense that the percentage change is negative, which is very good. So which already gives you an idea of how to prioritize. Then with the University of Washington, we have developed a prioritization tool, which is a visual way of seeing what the interventions will do in terms of shifting the mortality curve, the premature mortality curve, towards the premature mortality target. So one can actually look at the country and select a group of interventions appropriate to their context, like tobacco taxes, hypertension control, early detection and treatment of cervical cancer, and see what is the cost effectiveness. So such an interactive tool really helps, because unlike TB or malaria, where things are very straightforward, here we have a complex set of heterogeneous conditions with multiple interventions to be carried out by different sectors. So unless we get a grip on what can be done and how effectively can be done, we cannot sort of achieve coverage and expansion. We come back to the primary healthcare dilemma again. If you look at primary healthcare, there is a lot of effort globally to scale up primary healthcare, but the weakest link in that chain is non-communicable diseases. Primary healthcare across the world is very good in antenatal care, immunization, even in COVID testing. But when it comes to chronic care, when people have to be managed for 30 to 40 years for hypertension, diabetes, asthma, other mental health, other conditions, primary healthcare is not equipped in most parts of the world. So we know the solutions about teamwork and task shifting and digital solutions and protocol-based management and access to medicines, all the basic health system building blocks. But we have to see PHCs through the lens of NCDs. Does it really work? India has got a very good example called the India Hypertension Control Initiative, which has now 2.5 million people on protocol-based management. And the hypertension control rate in about 2 years has really gone up from 4 or 5% to 15 or 20%, which is a massive increase in terms of population coverage. And this is actually possible. So that means primary healthcare is the sort of way to improve access to NCD prevention and management. Finally, we need to bring all this together, and WHO has again developed this multi-sectoral action plan tool, which actually helps a country or a subnational region to go through assessment, engagement, developing a framework, implementation plan, and evaluation through checklist and tools, because then only we can actually bring all people together to carry out health in all policies. Finally, data, and these days data is plenty, but most of the time the data is not synthesized. So our suggestion is to bring risk factors, morbidity policies, and cost and resources, synthesize data with insights, and sort of lead to accountability so that there is action and we can achieve the targets. So with thanks to the Manchester team and everyone who has listened to me, let us look at non-communicable diseases as the next frontier. The world everywhere is going to have a high burden of non-communicable diseases. Since we have to go far, we have to travel light. Thank you very much.
Thank you, Cherian. We had some technical difficulty with slides. Can you hear me okay?
Not very well. Can you please make it a bit louder?
We had some technical difficulties with the YouTube. Is it possible for you to share the graphs just now quickly for the CVD that you just spoke about?
Which one can you?
I think it was the third one along. Yeah, keep going. Yeah, I think it was this one. Thank you. Cherian, is it possible for us to share your slides?
Yes, it is okay.
Brilliant.
Yeah.
Thank you so much for helping us again with all of your expertise in this field. We're running slightly behind schedule. Are you able to stay on the virtual plenary for a little bit longer?
Yeah, I'll stay a bit more from New Delhi. So thank you, Arpan, and thank you, everyone. I'll send the slides across. Thank you.
Lovely. Can I double check with the team that we have Professor Kevin Fenton, who is the president of our Faculty of Public Health here in the UK?
Yes, I'm here, Aparna. Can you hear me?
Hi, Kevin.
Hello.
Thank you so much. We know how busy you are, and hopefully you're enjoying your first few days as our new president.
I am actually, and this is actually my first speech as a new president. I'm looking forward to the discussion today and of course engaging with colleagues as well. So congrats on the International Festival.
Thank you so much, Kevin, and we're so honored to have you speaking to us today. So I will just double check with the technical team that the slides are sharing. We can see them here.
Great.
So I think we are good to go. Thank you, Kevin.
Wonderful. So good morning, good afternoon, everyone. It's a pleasure to be here with you at the International Festival. As you heard from Aparna, I'm the new president of the UK Faculty of Public Health, the body that oversees the training and development of public health specialists here in the UK and through partnerships around the world. Today, I've been asked to reflect a little bit on some of our work on urban health and some of the ways in which our thinking about urban health is evolving as we emerge from the latest phases of the COVID-19 pandemic. And what I hope to do in the time that I have available today is to, first of all, reflect on why we should have an interest in urban areas and urban health, to reflect on the impact, direct and indirect, that COVID has had on urban areas, to go a little bit deeper in the nature and scale of inequalities that we have observed, and then finally end by reflecting on opportunities. So as we think about not only the concentration of diseases and other emerging infectious disease threats borne by urban areas, what might we learn from COVID that should encourage us to do things differently? And I'll be looking at a couple of examples from here in the United Kingdom. So we need to focus on urban areas, in part because we know that increasingly we're becoming more urbanized globally, with greater proportions and numbers of individuals living in urban areas. And with those urban areas coming concurrent challenges on socio-political, economic, and health. Urban areas are important for a number of reasons, as highlighted on this slide. We know that they're areas of high population density, and both for an infectious disease prevention and control perspective, as well as the management of chronic disease prevention and control, space and density matters. Many of our urban areas are global and local travel hubs, include airports and harbors, train stations, and therefore facilitate both the incursion of infectious diseases and, of course, spread to other parts of the region or countries in which they exist. But also, these travel hubs may also provide opportunities for access to high quality health and care systems. They're often the sites of heavily used public transportation networks. And another key feature of urban areas is, of course, the density, subpopulations, population heterogeneity that we see, which provides the rich cultural diversity that we celebrate in urban areas, and which can provide challenges with engaging and mobilizing different population subgroups within place. Within urban areas, we often see a number of vulnerable, marginalized groups, which often migrate to urban centers because of the availability of support services or the greater economic environments which people are going to be in urban centers. So you may find increasing proportion of individuals who are vulnerable, marginalized in urban areas, facing the lack of access to safe housing, water, sanitation, a number of those wider social and structural determinants of health. And clearly, with the pressures of population movement, population density, high numbers of especially young individuals living in urban areas, there may be major challenges with the nature of work, the nature of employment opportunities, social drivers of health, as well as the structure of the economy, which can both facilitate as well as exacerbate health inequalities. Now, COVID-19 certainly has had a disproportionate impact on urban areas. And in fact, we now know that urban areas have been at the epicenter of the pandemic as it evolved at the beginning of 2020. It's estimated by July 2020 that the initial burden of diseases were seen in urban areas, with nearly 90% of cases reported in urban areas. And of course, as we've gone through subsequent waves of the pandemic, we've seen greater movement of infection from urban into suburban and rural areas through local and global connectivity. And we've also seen where urban areas were often the sites of the introduction and expansion of new variants of COVID-19. We know that features of urban areas such as the global housing crisis, high proportions of individuals living in poor or unstable housing, residing in slums and informal settlements also resulted in increased risk of disease transmission as well. And we know, certainly from work that we've done here in the United Kingdom, that overcrowded households and multi-generational households in urban settings were actually sites where we had acceleration of transmission throughout the course of the pandemic. So when we think of COVID's impact, we can think of it in many domains in terms of its demographic impact, its impact on whether or not individuals had prior exposure to infection, the kinds of job they did, their prior history of chronic illnesses that may have increased the risk of acquiring transmission or infection or developing severe disease. We can also look at place as a determinant of both acquisition and transmission risk for COVID-19. Now, as we think of space and settings, we know that urban areas have also been a key feature of driving and determining COVID-19 inequalities, in part because of this concentration in urban areas and the unique characteristic of urban areas. We know, for example, in the United Kingdom, in work that we did, that factors such as the high proportion of minority communities residing in urban areas meant that when the epidemic began to be expressed, we saw a disproportionate burden among our Black, Asian, and minority ethnic communities, especially in urban settings. And this was further compounded by factors such as the nature of housing, the nature and types of jobs that people did, access to and trust in healthcare services, and of course, the uptake of prevention interventions. So this pattern, even within place of disparities being amplified in COVID, was seen not only in the United Kingdom, but we've looked at other urban areas and we've seen similar patterns within place of this concentration and super concentration of infection. So inequalities such as overcrowded housing, reduced access to care, the distribution of non-communicable or chronic diseases, air quality, access to preventive services, all resulted in a disproportionate risk of either acquiring COVID infection or progressing to severe disease and dying from the infection as well. Now, as we've gone through the pandemic, we know that not only did place matter in terms of the risk of acquiring infection and transmission and expansion of the epidemic, but we're likely to see lasting impacts of COVID, particularly concentrated in urban areas. And this is for a number of reasons. Again, it reflects the demographic profile, the social and economic profile of our urban areas. We know that the economic impact of COVID has been disproportionately affected, especially in urban areas, by virtue of the job and economic instability that it caused, the disruption of businesses, and the failure of businesses to bounce back as quickly, especially in numerous urban areas compared to other parts of the country. In urban areas, we know that there had been a disproportionate impact on tourism and population movement throughout the course of the pandemic, and that for many urban areas has exacerbated the sort of economic impacts of the pandemic. And while we're now beginning to see a resurgence of movement and travel and migration taking place, that of course has been a significant economic impact for many urban areas. And then finally, because of the cultural and diversity, the social diversity, the mixing that normally happens within urban centers, again, the impact of the pandemic on areas such as the performing arts, live music, access to museums, and other cultural and creative sectors really took a hit throughout the course of the pandemic. And of course, as we're emerging from these phases, we're continuing to see lasting impacts on those sectors as well. So understanding not only the acute, but the lasting impacts of COVID-19 will be important. Now, by focusing on urban centers today, this is not to say that rural areas have not been affected, but what we want to do is to really explore some of the learnings from urban areas to understand what might we do differently to build resilience moving forward. But for those of you who are based and working in rural areas, you know that there have been also different and unique set of challenges faced by these areas as well. And here I've just highlighted just a few that we're also exploring and we have seen throughout the course of the pandemic. So we know that many of the containment measures were far easier to implement in urban settings because of the density of the population, the use of social networks, and the ability to manage mixing in urban centers. Whereas in non-urban areas, other super spreader events, large areas of mixing and different types of population mixing may have operated. We know that we have demographic differences in rural areas compared to urban areas. Rural areas tend to have a higher proportion of older individuals, and they tend to face greater numbers of comorbidities, which in turn increase the risk of COVID complications and mortality. Patterns of access to healthcare services may be different between rural and urban, and we know that capacity to respond to various waves of the pandemic tended to be better in urban areas than in rural areas. And finally, in areas in countries where we may have greater levels of proportions of indigenous populations residing in rural areas, we know that that also may have been associated with specific types of ethnic and racial health inequalities appearing. So those are some of the challenges that we experienced as we've moved through the COVID-19 pandemic. I've sort of highlighted why urban areas may be at risk and some of the impacts that we observed as we've gone through the pandemic. But as we're now poised to build back fairer and build back better as we emerge from the pandemic, what might be some of the opportunities for us, especially in urban settings, to do things differently and to build upon the lessons of the COVID-19 pandemic? So I thought I'd reflect on what are some of the generic and overarching lessons and legacies that we're focused on, certainly here in London where I work, as thinking about the things that need to change and need to be part of rebuilding the public health infrastructure and architecture for the city and ensuring that our population is more resilient. And we also like to look at 3 specific examples in mental health, in climate and the environment, and in building strong communities as to what might be different as we emerge from the pandemic. So across the city, in many urban areas, we're looking at a variety of lessons and legacies from the pandemic. And this is being informed by work that we're doing through evaluation and work with system partners to lock in those lessons and to change behaviors and cultures so that we can truly be more resilient as an urban area. And this includes ensuring that we have well-resourced, multi-level and equity-focused public health, pandemic preparedness, and emergency response systems working in the city, really building upon the lessons from COVID-19, our understanding of how infections were introduced, how they spread, how they created inequalities, and their impact on social, economic, and cultural impacts that they had in the city. Second, we learned a lot about the nature of partnerships which are required to manage threats such as COVID-19 and other emerging infectious disease threats, how we work across health and care systems, how we engage the volunteer sector, and how we work more effectively with the community as well as social care partners. Third, we've learned as an urban area about the importance of thinking carefully about the types of data that we have and how we have access to high quality, far more robust programmatic data, looking at our health outcomes and developing data systems which can provide much more immediate feedback on both the evolution of the infectious disease threat, but also to help us to evaluate the impact of our prevention and control interventions. And fourth, we realized the power of harnessing the partnerships with our academic colleagues and institutions to do the sort of rapid assessment, program evaluation, community participatory research that can help us to both target our interventions and to evaluate our interventions as they were being implemented. And then finally, another key legacy for us as an urban area coming through the pandemic is the importance of strengthened community-centered and asset-based community approaches, building on our community assets to help us with outreach and engagement and involving communities in being part of tackling health inequalities. So 5 areas where we're seeing lessons that from an urban center perspective that we're committed to taking forward. Now, we can apply these to specific areas such as mental health, and you'll see some of the lessons here that we're implementing in London and I know in many urban areas as well. Again, the impact of the pandemic, both direct and indirect, was absolutely clear about its impact on mental health. Throughout the course of the pandemic, we've seen the use of new digital tools and technologies, innovative evidence-based treatments that have been put in place, and that really took root in the urban areas within the country that we're now looking at both expanding, disseminating, and helping to change and inform our practice. Again, as I mentioned, we have been changing the way we partner, involving communities far more effectively, and ensuring that we build a much more holistic approach to resilience, which includes physical and mental health for local communities. And finally, issues related to healthy and good work. And because workplaces and occupational centers were seen as such an important part of the COVID-19 response, we've been able to strengthen our workplace programs, integrating efforts to improve mental and physical health. The second area that I'd like to focus on briefly is around climate and the environment. And clearly, throughout the course of the pandemic, especially as we've seen major population level non-pharmaceutical interventions, for example, lockdowns and social restrictions being in place, we were able to evaluate the impact of these interventions on climate. And we could see almost immediate impacts on air pollution, for example, as we've gone through the pandemic, which enabled us to understand the nature of interventions which would be required to to have significant impacts on air quality, and to think about how we may use further policy interventions moving forward to help us to introduce better climate adaptations as well as interventions for tackling and improving air quality. So again, really using the experience of the pandemic to help us to think through policies and their impact. Finally, the third area just to focus on is the work that we've done throughout the course of the pandemic to really think through how we do better by our local communities. Again, because of our work on tackling vaccine equity, engaging and mobilizing communities in health promotion for COVID-19, we've built new links with our local communities, which can now be harnessed for other health challenges and other health interventions. And a key part of what we're doing is the ways in which we are polling and engaging and understanding communities' needs better, building in community infrastructures, including community health workers, health ambassadors across urban areas to do better engagement, and the work that we're doing with local communities to build trust and confidence in our health services. Now, finally, just to wrap up the presentation briefly, just want to give two examples of how the learning of COVID in an urban area is helping us to change the way we approach health and to develop and build upon that sort of multi-sectoral, multi-partner engagement to improve outcomes. The first is the London Recovery Programme, which I'm involved with, led by the Mayor of London, where we've decided that emerging from the pandemic, building back fairer and building back better meant taking a holistic approach to thinking about the health and well-being of Londoners, building upon the lessons that we have on tackling inequalities. On the left-hand side of the box, you can see the 9 areas where the recovery program focused. And you can see not only does it focus on health recovery, for example, mental health and well-being, but it focuses on improving and creating healthier places, for example, high streets for all, thinking about the economic and social safety net, focusing on digital access, and of course, building stronger communities. And part of this work, which involved multi-sectoral, multi-partner engagement, recognized the importance of inequalities, valued collaborations, used digital, and thought about sustainability and health and well-being as a core part of what we do. And you can see on the right-hand side of the box some of the key outcomes that we've been working on in the city, which again places the health and well-being ambitions within the context of social and cultural and economic development for the city. A similar approach is being undertaken in Glasgow, where their social recovery task force has been brought together to drive forward a holistic recovery from COVID-19 within the city. And again, 5 areas for effective public mental health response is highlighted here. And again, this includes building resilience and maintaining population well-being, addressing isolation and loneliness and building social connections, really ensuring that healthcare systems and structures are in place to deal with the most common mental health conditions, including anxiety and distress and suicidal ideation. And of course, dealing with inequalities and thinking again about the workplace as a key place for intervention within urban settings. So colleagues, what I wanted to do today was really just to reflect on not only our experience as we've gone through the COVID-19 pandemic, but to think through what it has meant for us, those of us working in urban settings, to understand both the impacts, but also the opportunities for learning from these experiences and how in urban areas we may commit to doing things differently to achieve different outcomes. The Faculty of Public Health clearly has been a part of this journey, and our work in thinking about the functions and standards of the public health system are now being incorporated to ensure that as we rebuild better and fairer, we're looking at strengthening public health systems in light of our experience in the pandemic. And this includes not only system leadership for public health, but the ways in which we can leverage public health expertise to advance a number of our public health priorities for urban areas, whether global vaccine equity or work on climate change. So Parna, with that, thank you so much. Just a brief canter there through urban areas and our experience of the pandemic and committing to do better because we now know better. Thank you.
Thank you so much, Kevin. Can everyone? everyone hear me okay?
I think you're very faint. If you're speaking into the microphone, yeah.
I'll try again. Is that any better?
Yes, much better. Thank you.
Fantastic. And we also have Cherian on. So I'll just ask if there are questions from the audience or any questions if the team can tell me from the YouTube channel. But if I may take Chair's prerogative and ask the first one. Cherian, you have been in this role and doing this amazing work for several decades. What is going to be the most important thing as we go forwards now so that we can really start tackling NCDs, especially in low resource settings?
Arpana, is that to me, and are you asking for the priorities for low resource settings?
Yes, please.
Okay, thank you. I think that's important. Low resource settings have multiple challenges, but they are also in a good situation to prevent what is happening from high resource settings. As I have pointed out, childhood obesity is something that is that can be considered, because these are countries where new markets are being opened up, and this is the right time to put in restrictions so that we are not trying to retrofit, whether it is urban design or marketing of unhealthy food and beverages to children. And obesity is increasing across the world, including in poorer parts of the world. So it is more overnutrition or unhealthy nutrition rather than malnutrition now. Second challenge that I see is the alcohol and substance abuse, which has got multiple ramifications, not just NCDs, including road safety and violence, which needs more action. And the third most important thing is primary healthcare. Invest in primary healthcare now so that we can prevent complications tomorrow. Thank you.
Thank you. That's really interesting, considering we had so much activity that has focused on what we do in hospitals. So that's great to hear your thoughts on that, Cherian. So if I can come on to Kevin, as our new president, and as you start your presidency for the Faculty of Public Health, can we ask you for your thoughts in which we can try to get those conversations with our communities? You spoke beautifully about the need for building up trust and for co-production of the solutions. And just wondering, with your dual roles, what your thoughts are again on the priorities and how we can help as a public health academic and professional community.
Thanks, Aparna. Great question. You know, as I said, there are many lessons from the pandemic, and one that we must commit to taking forward is doing better by our communities. There are too many of our communities that feel disconnected from health and care services, that are mistrustful, and that don't feel respected. And that has an impact on how they access care, how they take up prevention interventions and care interventions, and that also influences outcome. So what I'm keen to see, Aparna, is that, you know, when we talk about, as the new president, the pillars of public health practice, which we often think of health improvement and healthcare public health and thinking about health protection, that we begin to think about some of those other important pillars as well. And we think about, what does it mean for public health practice? What sort of evidence do we need? What sort of training do we need to build capacity to deliver? So I would certainly want to see greater confidence in our public health leadership about community-centered approaches to improving health and tackling inequalities, to advance asset-based community development as a core strategy for us to build that robust infrastructure in our communities so that we can be more resilient in the future. I think public health leadership has a really strong part to play here, both in advocating for asset-based community development and approaches, but also to provide the evidence on what works and to hold to account systems, health and care systems, that they're doing right when it comes to engaging with and involving communities in their own health. We will not be able to get beyond the challenges that we're facing in our health and care systems unless we truly engage our communities and empower them to be part of the solution.
Thank you so much, Kevin. Yes, please, if you shout out and I'll... Thank you, Kevin. I think this is one from you, from one of our, Annie, is that you up there? Annie's one of our MPH students who was fabulous and has graduated and is now working in primary care.
Great.
And again, it was about the trust issue and looking at almost like an anchor organisations in terms of acute trusts and what's being trusted. But I think Annie's question is, how do we really build that local need for communities to be able to really think through some of those problems that they're facing?
Yeah, Annie, thank you so much. A great question. And I'll use the example from work that we're doing in London, because we had to engage our communities on the COVID-19 vaccine, because we predicted and saw when the vaccination program started significant challenges with vaccine hesitancy, myths and misinformation, and vaccine denial within some of our communities. So we had to do a lot of work to both build relationships and trust with those communities in order to overcome some of the hesitancy challenges. So 3 things that have been important, Annie. Number 1, recognizing that trust, which often took a long time to lose, will not be regained overnight. So part of the commitment is that we're doing this work and we're consistent and we are engaging with our communities moving forward, because what communities have experienced is the sort of inconsistency in the relationship and the types of relationship with healthcare providers. So committing to an ongoing, consistent program of work to build trust is the first thing. Second is ensuring that we have the structures in place so that we're truly listening to and engaging communities and being able to demonstrate that the advice that we're getting from communities are truly helping to change the structure and the ways in which we deliver services. Nobody wants to be brought onto an advisory board not to get their input or their advice implemented on or acted upon. So we have to have that very clear and transparent feedback loop. And then third, it's really understanding how we not only bring communities to health and care services, but that we meet communities where they're at. And that may mean changing the way we deliver services, more culturally competent services, much more accessible services. So we're meeting the needs of communities. And what we heard with the vaccine was that people wanted to see that their health system was not just focusing on meeting the needs of the majority and everyone, but where there were unique and special challenges, for example, language interpretation for services, that communities felt that those needs were being met as well. So we need to see tangible ways in which the services are adapting to and meeting the needs of local communities. So hope that helps, Annie, but 3 of the things that we're putting in place in London.
Kevin, for presenting here and answering our questions. There's several more. So if you don't mind, could we email you those questions?
Sure.
Thank you so much again.
Good. Great.
So moving on to our next speaker. Dr. Chandra-Mouli, lead for adult and sexual reproductive health. Hello and welcome to the festival. Thank you so much for agreeing to speak to us. Can you hear us okay?
Yes, please. Good afternoon. Can you hear me? Can you see me?
Yes, everything is going good. Are you okay sharing your screen for the slides? And
yes, please. Done.
Brilliant. I'll double check with the technical team that we're good to go. Lovely. Thank you so much.
Thank you. And good afternoon, everyone, once again. Greetings from Geneva, from the World Health Organization. Over the next 15 minutes, my colleague Elsie Aquara and I are going to share some good news with you. There's a lot of bad news in the world today, and you can just look around for that bad news. But it's also good to be aware of areas in which progress is being made. And despite COVID, despite all the other problems, good things are happening. I'm going to give you a global overview in one area very quickly. And then my colleague Elsie Aquara is going to take you through a story of Ethiopia. Ethiopia is mired in war and civil conflict today, a huge tragedy. But in the first 15 years of this century, in the Millennium Development Goals period, Ethiopia did some magic things, which we hope and pray can be replicated in Ethiopia, replicated around the world, and that Ethiopia comes back to its senses and to the track that it was on. Over the last 6 months, my colleague Elsie and I have put together facts and figures in a number of areas of adolescent sexual and reproductive health to demonstrate that progress, in fact, has been made, is being made, but that there is unfinished business. In this presentation, I'm going to talk to you about adolescent childbearing. We read a lot about adolescent teenage pregnancies, and we read a lot about the huge increase in teenage pregnancies as a result of COVID. The reality is that globally, over the last 10 years, there's been a slow but steady decline in adolescent birth rates and in the absolute numbers of births to adolescents. All the data that we are presenting to you are from reports published by the United Nations and other reputed agencies, and all of them are in the public arena. The next point is that there's been decline in adolescent birth rates globally, as you can see in this slide, from 60 per 1,000 girls 25 years ago to 44 globally, with South Asia and Sub-Saharan Africa making the greatest progress. Again, this is not often something that you hear. You only hear about Africa, Sub-Saharan Africa especially, as basket cases with bad news. But actually, great things are happening in many parts of Sub-Saharan Africa. Declines in adolescent birth rates, and the area in which progress has not been made is East Asia and the Pacific, where childbearing rates have increased slightly. Moving to child marriage. At 25 years ago, 1 in 3 girls in the world were married before the age of 18. Now the global estimate is 1 in 4. And as you can see from this slide, there has been declines globally in every world region, with notable declines in South Asia, declines also in Eastern and Southern Africa and Western and Central Africa, but not as markedly as in South Asia. So declines across the board, but uneven declines in different parts of the world. One of the places which is kind of stuck in this area is Latin America and the Caribbean. And here you talk about child marriage and informal unions, which are driving an adolescent pregnancy problem. Take contraception. If you talk about met need for contraception in adolescent girls aged 15 to 19, again, what you see is a huge increase between the mid-1990s to today, between 36% whose needs were met to 60% whose needs are met. But 60% whose needs are met also means that 40% have unmet needs. But what you see again here is a huge disparity. You know, whereas in Latin America and the Caribbean and Europe and Central Asia, 3 in 4 girls have met needs. In many parts of South Asia and Sub-Saharan Africa, the corresponding figure is 1 in 2. So again, progress is being made, but progress is uneven. UNFPA has just published this report. This report came out last week, Motherhood and Childhood, the Untold Story. And the key messages it speaks to is progress is being made. There is heartening progress, but it is slow, needs to be speeded up. But what they pointed to is that there are parts of the world where absolutely no progress has been made, where they're no different from where they were half a century ago. And that's what you see more and more, an unequal world. And so I conclude my segment of the presentation with this issue of context. What's happening is that in countries like India, where I'm originally from, Nepal, Ethiopia, child marriage and adolescent childbearing were global. They occurred everywhere. My grandmother, for instance, married as a young teenager. That's not happening didn't happen in my sister's case, will not happen in my daughter's case. And this is changing across the country. But there are still pockets of poverty, intersections, vulnerabilities, with various things coming together: caste, religion, economic status, rural residence, and all these intersectional vulnerabilities contribute to pockets of lack of progress. So progress has been made in many areas, in HIV, in adolescent childbearing, in child marriage, in female genital mutilation. The one area in which there's been very limited progress is intimate partner violence and sexual violence. We'll come to that if we have time in the discussion, but I really don't want to take time away from my good friend and respected colleague Elsie Akwara, who's Kenyan American, from this slide you can see that she has a powerful track record in data analysis and research. Over to you, Elsie, to take us through this just published paper.
Thank you so much, Chandra. Can everyone hear me? Can you hear me?
Yes, please, go ahead.
Thank you. So as my colleague Chandra had mentioned, that we did a case study in Ethiopia looking at adolescent sexual and reproductive health and rights in Ethiopia over the last 2 decades. That's spanning, we published this paper, we started working on this paper in 2019. So when we're looking at the last 2 decades, it was prior to 2022. Next slide, please. So I have 3 points to make. The first one is looking at the last 2 decades, how the political and socio-economical developments has shaped the national health and development policies and programs that have contributed to the changes in ASRHR. Next slide, please. So here we look at the improvements in the socioeconomical context. We've seen that the gross domestic product has grown and the poverty level has decreased. And we see that the Ethiopian children are living in a context where poverty has declined. We also see that there's been impressive progress in primary school enrollment, But also at the same juncture, we see that there's limited progress in primary school and completion rate in secondary attendance and completion. And then we'll also see uneven rates within the country. Next slide, please. We also see that there's been a significant contribution of national health and development policies and strategies, which includes all facets of SRHR, such as HIV, maternal mortality, childbearing, and intended pregnancy, FGMC, which has contributed to a number of ASRH outcomes, which leads me to my second point that highlights the substantive health outcomes that have occurred within the country. Next slide, please. So here we can see an example of 4 different levels and trends that have occurred within the country. So we see 3 significant health outcomes. One of it is on child marriage, which at least you see a 9 percentage point decrease over the years between 2000 and 2016. We also see a significant increase in modern contraceptive use, both in postpartum contraceptive use, family planning contraceptive use, and then also in just the overall general modern contraceptive use. Especially when it comes to modern contraceptive use, at least we see about a 34 percentage point increase between 2000 and 2019. We also see a decrease in the adolescents who have begun childbearing. So this data is for those adolescents aged 15 to 19 years old. Next slide, please. We also observed significant health service uptake for the adolescents, also at the same age group between 15 to 19-year-olds. We're looking at antenatal care. That means 4 or more plus visits for those adolescents who are pregnant. And then also at the same time, we looked at stillbirth attendance. We saw a significant improvement between 2011 and 2016, with at least more than 21 percentage point increase between 2000 and 2016. While we don't have enough data for abortion, we have seen progressively in this paper that we have quoted earlier on, and then also we can share it at the end of the presentation, that abortion services have become legal over the 2 decades that we were examining in this profile. And we see that more adolescents are seeking abortion services in health care facilities. So clandestine abortions seems to be less likely, and we have more adolescents seeking care at the health facilities. Next slide, please.
Just a minute, Elsie, with your permission, a small correction. So
Yes.
There's not been any change in laws on abortion. What they've done is they've liberalized access to abortion within the framework of existing laws. So,
Exactly.
for instance, a young woman who can come and request for an abortion for social reasons, and the barriers that were there in place, which prevented her from even asking for the abortion, let alone getting it, have been reduced. So they are able to obtain services in the context of existing laws.
Okay.
Over to you.
All right. The other health outcome that we looked at was looking at the HIV incidence and the prevalence level, as well as condom use. And we see that there's disparities between males and females, where we see that females are more disproportionately affected by the HIV. But we see that there's a decline over time between 2000 and 2016. We see also that there has been a sharp increase between 2000 and 2011 in terms of condom use, but a sharp decline towards 2016. This could be attributed to the condom stockouts and diversion of funding to other health outcomes. Next slide, please. So here we were looking at female genital mutilation and or cutting, and as well as gender-based violence. With regards to the female FGMC, we saw that there was a decrease between 2000 and 2016, at least 24 percentage points. And also between those who are aged, who are younger aged, between 10 to 14 years old, the teenagers, we see also that at least 28% experience FGMC, but there is variation within the country. So there's a need to assess the subnational level with regards to FGMC. So that means that there's some sociocultural norms that are underplaying within the country. When we come to gender-based violence, we see that there's a decrease. There is still at least 33% that have experienced gender-based violence, but at least we see the gender norms in terms of attitudes towards wife beating decreasing amongst the younger population, among adolescents, boys and girls. Next slide, please.
Just to reinforce, in all the statistics we've shared with you, the one area in Ethiopia, just like in many other countries in which there's been very little progress, is in intimate partner violence and sexual violence.
Thank you for that addition, Chandra. And then my third point is, as we look to the 10 years, so we acknowledge that there's progress that has been made. So we have to build on that progress and then also move ahead in understanding and overcoming challenges and making full use of opportunities. Next slide, please. So with regards to opportunities, we understand that Ethiopia has an enabling environment and which is well resourced, managed and implemented. And it comes at a multi-sectorial juncture. As Kevin Fenton, the speaker before us, had mentioned, there is a need to have a multi-sectorial involvement when we're looking at dealing with minority involvement, minority populations. And we do understand that the Ministry of Health has built partnership, which also involves the local level. And in Ethiopia particularly, that we do have health extension workers that has been working with the government that ensures that that they are well resourced and well aware of the communities that they would serve. Further to that, there are also challenges moving forward. There's an uneven awareness of enabling laws, policies, and strategies. And this implementation sometimes has been hampered by lack of both human and system capacity. And then there's also some restrictive social norms which are coupled with resistance in some quarters, in some certain aspect of ASRHR. Next slide, please. Moving forward, there are some key actions that the Ethiopian government can take, and then also other countries similar to Ethiopia can be able to learn from the Ethiopian case studies, which is making full use of the existing political support of ASRHR, challenge and change social norms affecting ASRHR, and also strengthen investments, both domestic and broadly. And we have to ensure that there is strategies which are evidence-based. We have to collect data both at the national level and the subnational level, and we have to be cognizant of the fact that there's the COVID-19 pandemic and the issues that are happening within the ground given the current circumstances that are happening within the country, and also to ensure that the national adolescent and youth strategy increases in scope with scope, especially with its implementation mechanism and resources and infrastructure. And with that, with further ado, I'd like to highlight also that it's important also to engage with the youth, and that adolescents and young people are, although they feature in a lot of their country's implementation programs, they're not fully implemented or they're not fully supported within the country. But youth engagement should also be complemented with technical and financial support, as I mentioned earlier, both domestically and internationally funded. Chandra, if you want to add anything there. Okay, so I'd like to acknowledge that this work has been done with support from the Ethiopian Ministry of Health, academics, NGO staff, UN agency staff, and 2 young people. Thank you.
Thank you, Elsie. Just to close by saying that in every piece of work we do, we involve young people. So we had a young man and a young woman from Ethiopia as part of the writing team. They were selected based on their work in this area. They were supported to deliver to the best of their abilities. They've been acknowledged as co-authors, and they've been paid for their time, unlike the adults who weren't, because this is part of their work. Over to you, Madam Chair, and thank you.
It's amazing work that you've done. If it's okay, we will hear Remy speak, and then if you're both okay to take questions afterwards, that would be great. Remy?
Ready to take questions, but we can hear you only very faintly.
Oh, sorry. Is it okay if
much better now? Thank you.
Questions after we hear our next speaker?
Go ahead, please. Okay, thank
you. Remy, can you hear me?
Yeah, Apana, I can hear you. I'm just trying to see if I can share. Just, I can see my, can you project now? Or?
We can see you, Remy. Lovely to welcome you to the festival. Thank you so much for agreeing to talk.
Thank you. I do not seem to.
Do you have the share screen option?
I do, but I can't see the presentation. Do you have it handy there? Okay, sorry, I got it here. I don't know if it's visible at all.
Yes, I have your presentation. Is that now coming up on the screen for everyone? Brilliant. Remy, do you mind doing next slide, please? And I'll go on.
Okay, great. So everyone can see. Okay, good. Really, thank you very much for inviting UN Habitat to share with you some thoughts on this very important topic of public health, with more focus on the urban dimension. So I'll be looking very much from, I would say, 2 perspectives: the dimension of governance that was talked about earlier on, and the urban dimension. So these are the 2 things I'll be looking at, and putting that very much in the context of the pandemic and how this can be managed through that collaboration and cooperation in an urban setting. So I would, I think it was already mentioned earlier by Professor Fenton, why it's important that the urban area is so important when we are talking about public health in general and how the collaboration is critical. So I will look at that and share with you some instruments and some aspects and some findings that we have come up in the context of COVID. So I will not dwell on this, but just to make the point that the concentration of people, human in certain settings creates some specific elements in terms of managing public health. And when it comes to the issue of the pandemic, for instance, it becomes very much obvious how the collaboration will be very critical. And the issue for us, urban health, had many dimensions, but mainly the physical dimension and the personal or social dimension as well. And I think was already touched upon the importance of community, but I just want to highlight the issue that is not only, it's really how the environment can be also conducive for better health as well. And I think we look at the different dimensions, different aspects that had to be part of the public health, from the, we already heard of NDCs, chronic diseases, mental health, and spiritual health. All that is part of that public health that we be covering here. So we know that the connection between the spatial factors and the public health is very much interwoven. So we could not stress, you have to stress really that importance of connection of health to the space and the context that is actually manifesting itself into. So, the urban settings, if seen as a territory or as a system, has many parts that had to be considered when we talk about health. We already heard some specific issues that are in urban settings that we might not necessarily find at the same scale or the same level in rural settings. So that's why we have to look at not only in urban and rural, but also intra-city. We already had some speakers mention the context of informal settlements, for instance. It's not the same type of exposure and issues that can be found there just because of the nature of the spaces and access to services and some of the infrastructure. So let's maybe now take that in the context of the COVID-19, that how some of the key lessons that we have learned through this. And we know that we already heard the figure of the concentration of the cases, but we know that when it comes to air quality, for instance, that many are suffering now. Even the heat is very much concentrated in urban settings because of the build-up, because of the nature infrastructure that we have. So why, we have to work differently in the context of governance and cooperation for addressing health as a public goods. And here, maybe I have to just stress that for us, governance is not only about public governance, it's about what we call the network of governance, where informal arrangements, community and other actors are part of that governance. And this has been shown again and again in the context of pandemic, that it could not just be a matter for governments only, but also other actors to come in and play an important role. And this was very much, just if we zoom in into the public sector, the local authorities play a very, very much important role, sometimes in challenging some national guidelines and come up of taking more initiative, more daring, more in, taking over some decisions that could really impact the life of people living in cities. So in that context, health became one of the core functions of local authorities that in the past they had not seen such. So why is it important? Because of the concentration. We We know that the concentration of people in one space require different ways of addressing this. We have to look at the past, knowing that we have been through different pandemics, and there have been some successful ways of addressing that. And that the spatial dimension is very important, that we have to look at the diversity, and that there might be, you might have some guidance, but not necessarily blueprint all over that will apply everywhere and to every actors, so that they need to be adopted and adapted in some contexts as long as it works. Now, we know that some of the issues have been challenged in terms of, say, rights and responsibility. So when it comes to some restrictions that have been, you know, defined to manage the pandemic, that challenges what we know traditionally as system of governance. And so some of the things we have taken for granted as a way to govern cities were put to test. So new ways of engaging, collaborating with different actors were also very important to look into. So what we were looking at was what works. So in terms of effectiveness, what are the type of measures that could really make a difference? What type of factors or conditions that would help, you know, addressing through collaborative actions the issue of public health in the context of pandemic, and what type of coordination and cooperation mechanism work. And again, I stress here that it's more inclusive type of collaboration and cooperation. It's not just the traditional vertical and horizontal type of governance or cooperation, but really wider. It's a network, it's a net of coordination. So, and also revisit some of the principles of what we call democracy, rule of law, and human rights, and know that in terms of crisis, some of these principles had to be contextualized in the spirit, in the idea of saving lives and for the interest of everybody. So just to give you some ideas of some of the key lessons that emerged from the looking at how cities, how local authorities, how different actors had managed the pandemic, really in terms of collaboration and cooperation. We have produced a report that we released. The report had 4 main parts, but I will focus very much on what type of regulations and governance mechanism we have put in place to make that work. We earlier heard a lot about the importance of equity, which was already addressed, and the issue of space that was also looked into. We heard a little bit on the economic or the impact of that. So, but I will not talk about that now. But just looking at the governance, some of the things that were important was looking at different ways in which cities were structured, planned, and how that different actors could look at, revisit the way in which infrastructure and services were accessed, used, and managed in the context of a pandemic. So to do so, it was important that we look at different measures, different policies, different countries, different actors, and see what seems to be working and the type of outcomes they were able to address. So just addressing the question of what works where and under which circumstances, we came up with some recommendations that help us understand that in this, what have been termed as new normal. We heard earlier about building back better, building back fairer. What is important is that we have to look at the spatial or territorial governance. So the space becomes so important. We have to think from the connection between the smaller unit of management from neighborhood to, you know, inter-municipality or international type of collaboration, and see what type of coherence can be developed through that. The issue of transparency was important. We had some words such as vaccine hesitancy, because if there are the communication when it comes to collaboration and the roles and responsibilities are not sometimes well structured, that was one of the things that, and the issue of trust. was not there, then it becomes very important. And more importantly, how do we put a system, a mechanism in place for a fairer, transparent, and justifiable type of collaboration and contribution where, and I like the last presentations, where all actors were acknowledged and appreciated. At times, it's not the case. The mayor will come and say, I have done this, I have done that, without acknowledging the role of other actors in actually reducing or, positively impact on the COVID cases, for instance. So the issue of acknowledging the contribution of all actors is part of that governance system that had emerged from the COVID-19. So just to look at some of the conclusions that had drawn from the 4 parts of the report that tied together the social part, which was the equity, the economic, and the spatial part, then the legislation and governance. I think that many cities or the context of agglomeration provides many opportunities to actually impact a larger number. So that was a positive thing. The same thing as the previous paper said, they have good news. So the good news is that in a city, you can manage much better if you use more collaborative approach. And there was a strong call that we need, based on that, we have to start thinking of a new ways of engaging, what we call the new social contract for collaboration, for working together, for moving forward together, so that the recovery could be more equitable. And that certainly the way we plan how people live, and we have seen now even in Europe that some of the cities were not prepared to address, to be able to cope with the heat. For instance, the housing, the type of infrastructure we have, the type of services we have are not equipped for some extreme cases. So this is very important. And within the UN, here we are speaking somehow along the same line from what you can see even from WHO and others, that we have to really look at collaboration across nations, across institutions, and looking in the same direction. And finally, looking at balancing the roles and responsibilities, not only rights, but we also have obligations. So balancing those are very much important. Some of the principles that are emerging, so that in terms of research and ways in which they can help refine some of the things we know, it's very important that health equity, that when we talk about health, equity is really put at the center, where we look at the more of the potential side of it, rather than the challenges, where we bring out the best out of the actors that are there, and preparing a platform, a mechanism that helps actors to contribute and to be acknowledged through their contribution. So this is very important in terms of equity and the new way of governing our cities with due consideration and due acknowledgement of all actors. We have also understood that it's important that whatever we do, if we cannot improve the health outcomes, then we are falling short. So putting health at the center of any policy actions is very critical. So we can really achieve social improvement, development, economic development, environmental sustainability, if we don't put health, and here I mean environmental and social health, at the center of such development. So that should be our higher aim. We already heard, and everyone agrees here, that community engagement is very important, and they should not be taken out of the governance of some of these issues. And that equity, again, is really empowering the potential, tapping into the potential, and that we have to be able to ascertain what are the elements that promotes the well-being, that reduces disease burden, and what are the things that really contribute to health determinants in different contexts, not the same everywhere. So this is very much at the center, some of the key principles that should be guiding us. Just to say that through that, we have to be able to measure. So we have, through one of some of the work we have undertaken, proposed some set of indicators through the publication on the how do we leverage what I'll just talk about, all these multi-level governance approaches to promote health equity, a set of elements, indicators that can help you track and ensuring that there's the network of governance that promote health equity for all. Another important elements to consider moving forward is that context matter. We should always look at what is so unique in that context so that we can address really the matter related to that. I already mentioned the issue of network governance, distribution of responsibility in terms of the gender dimension is on the same issue we have heard earlier on the case of Ethiopia on gender issues and reproductive health. And also you have to look at urban, rural, but also those who are spaces that are the interface. We have to look at those and because they have unique features that are emerging as well. So each space matters. The other element we have to look into is the issue of coordination of all actors or all sectors with entry points to support health equity for all. The guide will also really emphasize the importance of taking care of those who are the fringe, those who are vulnerable. It's very important that specific needs, attention is given to that case. And the issue of harnessing the potential of technology or other instruments you may have on, really taking that positive elements that we have, instruments we have to promote health equity. I will just finish off with some example just to give you an idea of how it works. We had, in terms of managing urban spaces planning, we had come up with a series of case studies that helps look at how planning can promote health, the governance of health with a focus on equity. So you can look at that. And there are two cases I'll mention here. One is in Kenya, where we have these multiple kind of outcomes out of the case, where we look at how different actors work together, where we look at the issue of sanitation, where we look at the issue of the financial dimension, the cost effectiveness, and many. So this multifaceted intervention sometimes bring out better, really that issue of equity. The other case is in Nigeria, they're focusing this time on the linking the local to the metropolitan and national level. So how actions at local level can inform and actually be acupuncture to impact, to radiate across the metropolitan area. So this is also an important element, and bringing all these actors together with through intervention on planning, infrastructure that improves also environment for well-being and health equity, as I was referring to earlier. So we have more resources for anyone interested that you can look into at your leisure. So let me stop here and thank you again for this opportunity to share a few thoughts on a few things that we are doing, again, in the area of governance for equitable public health, and some instrument that we had also been deploying. Thanks a lot, Apana. Over to you.
Thank you so much, Remy, and we hope that we will be able to see you all in Manchester very soon. But in the meantime, I'll just see if there's any questions from the audience. Any questions there? will you just take a question from online? So, Dr. Chandra-Mouli, in terms of the work that you're presenting, are they based around specific regions, or is it something that is extended across the different WHO regions? Dr. Chandra-Mouli, could you hear us?
Very faintly. I could hear you speaking, but I didn't hear what you said.
Sorry about that. A question.
This is much better. Thank you.
Online, which is this work quite regional specific, or is it being undertaken from across the different WHO regions?
Thank you. You know, our work is global. In fact, we've documented England's teenage pregnancy strategy, the huge success of the strategy during the Tony Blair years. We are now documenting Scotland's teenage pregnancy strategy, which has a strong equity focus. But because we wanted to give you details of progress in a country, we chose Ethiopia. The example that I gave you in terms of progress in childbearing was global data. But we gave you the example of Ethiopia. Yesterday, we published a case study of a 40-year program in Jamaica to address adolescent mothers. So WHO's work is global. And as we saw with COVID, just because a country is rich and has an old school of public health, doesn't necessarily mean it can get the best public health strategy in place. We saw that very clearly. Thank you.
Thank you so much. Question for Remy. In terms of the indicators that you've constructed for the governance side of things, how widely is that being adopted?
Thank you very much. I think that's something we work on this with WHO, with colleagues from WHO, and we have been, at least in the case of some of the projects we are working on, we have been using those indicators to really bring out the elements of equity, not only in terms of informing the project to ensuring that the equity dimension is well embedded in the project design, but also sharing that with our independent evaluators who usually review our projects to check to what extent some of these things have been used. So this have been used very much, at least from our side, in our projects, but we have not yet, we published it last year, I think. We have not yet widely evaluated the outreach in terms of how other actors would like to use such indicators in their own operations. So we'd be more than happy to discuss and evaluate, assess with anyone who's interested in implementing such indicators for their projects or their programs.
Thank you so much. So thank you to all of our speakers. Very grateful for you joining us, and it's been really interesting to hear about all the fabulous work you've been doing. Thank you so much.
Thank you and good afternoon. Thank you for the opportunity.
Thank you. Thank you.
Thank you. So for the team, please do enjoy your lunch. We have our special plenary in here, as well as the parallel sessions in the other rooms. Please check your programs, but please enjoy lunch, and I can hear the choir is singing already. So thank you so much. Thanks.